Malo lele, good evening everyone. Kia ora, warm Pacific greetings. Talofa lava, maloni, nisa bolavinaka. Welcome to the University of Otago, o tako whakaihi waka, on this very, very special and significant occasion. My name is Professor Diane Sika-Poltonu and I'm the Deputy Vice-Chancellor Pacific, and it is my great pleasure to have the opportunity to welcome you all this evening, and as we've come together to celebrate Professor Stephanie Woodley's Inaugural Professorial Lecture and also mark her wonderful career and contributions to academia. To begin with, just a couple of acknowledgements to start with. Acknowledging mana whenua. Of course, all of our distinguished guests and visitors who are here in person, but also who are joining us online this evening, and consisting of loved ones, family members, friends, colleagues, whānau, ainga, gainga, and many, many others. Welcome. It's great to have you here, and we thank you for making time to join us. You will see that down the front we have a very large academic party tonight, so I'll introduce everybody, starting with Professor Julia Horsfield, who's here on my far right, who is the Dean for the School of Biomedical Sciences. Tēnā koe, Julia. We also have, from the Department of Anatomy, Professor Stephanie Woodley. Welcome, tēnā koe. Great to have you here, Stephanie. We also have Emerita Professor Helen Nicholson, someone that you might have heard of before, also from the Department of Anatomy. Tēnā koe. It's so great to see you again, Helen. Malo. We have Professor Greg Anderson in our midst as well, who is the Head of Department for Anatomy as well. Tēnā koe, Greg. And last but certainly not least, our Pro-Vice-Chancellor from the Division of Health Sciences, Associate Professor Megan Gibbons. Welcome, Megan. Thank you for being here. There are other very special people to mention in the room this evening and who are also joining us virtually through the live stream. So beginning with Stephanie's husband Brett and their children Kate and Nick. Now Brett, Kate and Nick, where are you all? So everybody, they're here in the front row. So welcome, it's great to have you guys here this evening and a privilege to see you all. We also have Stephanie's parents, Margaret and Ken from Wanaka, and sister Kirsty from Dunedin. Please, could you give us a wave so everyone can see who you are and where you are? Welcome, it's great to have you here as well. We also have Kevin and Morag from Waikanai. So Kevin is Stephanie's father-in-law. Kevin and Morag, where are you both? Also here in the front row, welcome. And joining us online, we have Stephanie's sister Carolyn from Wanaka and the extended Mackenzie and Ralston and Morgan families, the whole lot of people, mainly in Wanaka, I believe, and there are some based in different parts of the country. So welcome to you all and thank you for linking in tonight. We also have mother-in-law Robin and Dave all the way from Napier who are linked in and joining us on the live stream as well, as brother-in-law Darren and sister-in-law Lisa from Auckland. So to all of you who are here and all who are joined online, welcome to you all, but to those who I've named especially, a very, very special warm welcome to you all. This is indeed a very wonderful occasion and a privilege to have the opportunity to hear more from Professor Stephanie Woodley herself with respect to her journey, her career, but also her wonderful contributions to academia. And as many of us here will know, that the journey to becoming a professor at the University of Otago is not an easy one. There are very strict criteria to be adhered to and also to meet, often numerous groups and individuals involved in the processes, including senior leaders, colleagues within the university, external to the university, national experts and international experts who are all consulted with in different ways and who will scrutinise academic work very, very closely. So by the time somebody reaches the level of professor, this can have taken quite a long time. And so to have reached professorial status, Professor Woodley, signals that excellent work and leadership has been demonstrated and also achieved and sustained over time across research, teaching and the service domain areas. And tonight, we will all have the privilege of hearing more about Professor Stephanie Woodley's areas of expertise, including important parts of her career and work as a physiotherapist, and also about her work in anatomy. We are also reminded as we gather together this evening that none of us journey through life alone. and that there are often so many who help us along the way. Given that academia is certainly not for the faint-hearted, tonight, everyone, we have an opportunity to recognise and acknowledge those who've walked most closely alongside Professor Stephanie Woodley. So I would like to please ask that you would join me in acknowledging and recognising Professor Woodley's family, who are both here in person but also who are gathered online. Congratulations again, Professor Stephanie Woodley, on your well-deserved promotion. We are very, very fortunate to have you. It is now my privilege to also hand over to Professor Julia Horsfield, and I would like to ask that you would please put your hands together to welcome her to the front. Malo, thank you.
Ngā mihi nui ki a koe, Diane. Associate Professor Gibbons, tēnā koe. Professor Nicholson, tēnā koe. Professor Anderson, tēnā koe. And Professor Woodley, tēnā koe. Tēnā koutou katoa. Nau mai haere mai ki te kaupapa o te wā. Ko Julia Horsfield tōku ingoa. Ko o te tumuaki o te Kura Biomedical Sciences. Nō re rā. Nau mai haere mai. Tēnā koutou katoa. Good evening, everyone, on this absolutely beautiful day in Dunedin. I hope some of you all got out and enjoyed some sunshine. It's my huge pleasure to welcome you to this very special occasion, the inaugural professorial lecture of Professor Stephanie Woodley from the Department of Anatomy. Tonight, we celebrate not only Steph's academic achievements, but also her remarkable contributions to research, education and leadership. Stephanie's academic journey began right here at Otago with a Bachelor of Physiotherapy, followed by an MSc with distinction in physiotherapy. Her PhD, which was completed in 2006, examined the anatomical basis and clinical diagnosis of greater trochanteric pain syndrome, which I think is hip pain, right, Stephanie? Yeah. Had a bit of that myself. Yeah. So hoping you'll have some answers tonight. So Steph's physiotherapy background has really shaped her research focus on the clinical and functional anatomy of the musculoskeletal system, particularly the pelvis, the hip joint, and the lower limb. Steph's research has had a profound impact on both science and clinical practice. She's led projects on gluteal muscle structure and function and hip-related pain, the management of pregnancy-related pelvic girdle pain, and digital technologies for pelvic floor muscle training to help women manage urinary incontinence. So these studies have informed physiotherapy practice and improved healthcare globally. Steph's work is highly collaborative, spanning teams in Australia, Canada, Brazil and beyond, and includes contributions to Cochrane reviews and international consensus guidelines. She has published 72 referee journal articles, with nearly a third of these in the top 25% most cited articles worldwide. Her work is of high importance internationally. Steph is the section editor for the pelvic girdle and lower limb in Gray's Anatomy. I think some people have heard of Gray's Anatomy. Yeah. So both the 42nd and the 43rd editions, and this is a role that speaks volumes about her expertise and reputation in the field. She's played a really important role in the development of postgrad students, having supervised 7 PhD, 3 masters, and 17 fourth-year students to completion. But not only that, Steph's contribution in academic leadership is outstanding. Her service contribution is substantial, and it involves extensive knowledge of discipline and a deep understanding of curricula and best practices in education. So for her sins at being really good at her job, I guess, Steph currently serves as Deputy Head of Department in Teaching Anatomy, and has previously held roles such as Associate Dean Academic for the School of Biomedical Sciences. She has taught clinical anatomy for over 15 years and redesigned curricula to integrate innovation using Te Reo Māori and received multiple awards for teaching excellence, including the University of Otago Award for Excellence in Teaching and the School of Biomedical Sciences Distinguished Academic Teacher Award. Steph is also the editor of the New Zealand Journal of Physiotherapy and currently serves as the president and of the Australian and New Zealand Association of Clinical Anatomists, alongside leadership roles within the International Federation of Associations of Anatomists. So tonight's lecture, which is entitled Beneath the Surface, Integrating Anatomy and Clinical Practice, this perfectly reflects the essence of Steph's career, which bridges anatomical science with real-world healthcare. In her presentation tonight, Steph will outline some of the highlights of her career as a physiotherapist, her transition to anatomy, and her work to bring both disciplines together through her research, her teaching, and outreach activities. Please join me in congratulating Professor Stephanie Woodley on the significant milestone. Stephanie, we're delighted to have you share your insights and vision with us this evening. No mai, haere mai, please welcome Professor Stephanie Woodley.
Thank you. E te ti, e te tā, tēnā koutou katoa. Nei rā te mihi kia korora, ko Diane, ko Julia, tēnā korora. Ki te mana whenua, rapawai, waitaha, ka te mamoe, kaitahu, a mihi ana kia koutou. Tēnā koe Megan, tēnā koe, tēnā koe Helen. This is annoying. I'll refer to this one. Kia koutou, oh, hoki. Oh no. Right, we're back at the start, good. Kia koutou, hoki, kua tai mai nei, tēnā koutou, tēnā koutou, tēnā koutou katoa. Mori ora ki te whānau. Next slide. Ko wai au, ko tapo nuku, te moka, ko pomahaka, te awa, no tapanui ahau, I kare kai otipoti tohuku kaika anai nei. Ko Mackenzie, tohuku I kua whānau, ko Steph Woodley, tohuku I kua no reira, tēnā koutou, tēnā tātou katoa. Dear esteemed colleagues, friends and whānau, it's a real honour and privilege to be here this evening, and I'm grateful to you all for coming. I think I can probably step away because Julie has told you all you need to know. So this has been coming for a while, and I'm quite glad it's here now, and I think we'll try and keep it short. Kevin was slightly mortified that he'd have to listen to his daughter-in-law speak for longer than 15 minutes, so never mind. I chose the title for this talk based around the idea that a lot of our anatomy is beneath the surface, meaning you can't always see it. And also, as you all know, and Julie's mentioned this as well, no man is an island, so we can't always, we don't do this alone, so there's a big team of people behind us because so much of what we do at the university and beyond is working together as a team. So I want to acknowledge the people as I go through. So you had a little snapshot of this before, but as I mentioned, I grew up in Tapanui, so a relatively small rural community. This is a photograph of our family in the early 1990s. So Mum, Margaret, is a teacher, Dad, Ken, was a butcher, and that's Carolyn, Kirsty and myself sporting matching outfits and hairdos. So I attended Tapanui Primary School, so that's me in the front row, second from the left, dressed in brown. Not sure that I looked that happy to be there. And then I went on to Blue Mountain, went on to attend Blue Mountain College. So while we lived in a small town, this did come with many opportunities and chances to give things a go. So Mum and Dad instilled in all three of us, I think, the values of education and also work ethic. So as you can see, I was also part of the school magazine committee. That was in year 12. So maybe that was a start, who knows. But I did want to acknowledge at this time Lorraine, who is the English teacher, kitted out in brown again. But Lorraine was our English teacher and a close family friend. Now, when I was at school, I was deciding whether or not to do law or physiotherapy, and I can clearly remember Lorraine saying, "You should become a physio, all you need is a pair of togs and a lab coat." For those of you who've done physio, you might understand. I'm not sure if that was true or if that swayed me, but that is what happened. And so going forward 10 or 15 years or so, Lorraine kindly offered to proofread my theses, so my master's and my PhD theses, which was a very generous offer, as you'll know if you've had to do such things. And if you're interested to know how she did this, she read from the end to the beginning backwards to check the spelling and grammar, so that was well before Grammarly existed. So I went to university here. This is a fairly motley looking crew. Some of us aren't looking at the camera, some of us have our eyes closed. But when we went to university at physio school, we were split here between the university and the Polytech campuses. I graduated in 1995, and I'm grateful that many people in this class remain friends and colleagues to this day. And so at this point, I did want to say a special hello to Kelly, who is online somewhere in Napier, Helen, who's here with Matt. We've known each other for a long time, so thank you for being here, as well as Jane and Megan, who are in the bottom photo. So following graduation, I did a short stint in Christchurch, working as a physio and part-time nanny for mum's cousins Kim and Cam. And then I moved to Napier. And when I was in Napier, I was a rotational physio, so I worked both between Napier and Hastings. And it's here that Brett and I met, and Brett's also a physio. He was a year behind me, but he's older than me. And then, just to clear, before setting off 2 years later on our OE. So we went from Napier to the UK, and we lived in 5 different places, so they're shown by the stars on the map. If you are familiar with the UK, these probably may not have been the most salubrious locations. So we started in Wolverhampton, and then the 2 stars north of that are Stoke and Crewe, and it looks like they're joined by a nice river, but that's actually the M6. We had some time over the east coast in Lowestoft on the Norfolk Broads, and a 6-week stint in Dover. So we lived in the nurses' hostels. It was about £50 a week. That was all inclusive of electricity, heating, etc. And this was in the days before cell phones, so you had to go to the end of the hallway and use a real phone to call home, accompanied by a prepaid calling card. Did it go? Yes. So this is, I think the top photo is a picture of Buckland Hospital in Dover, which looks quite different these days. And then I think in the next one was a leaving do in another physiotherapy department. So all of the physios in the room will know that the hallmark of a good physiotherapy department is the quality of the morning teas. And so while in the UK I worked quite a bit in musculoskeletal outpatients or on the rehab wards, we were exposed to the realities of the NHS, but also met many amazing people. So we also made the most of our opportunities to catch up with friends in all corners of the UK. This is Kelly in younger versions of Helen, Matt and Brett. I think the top one is in London, and then the bottom one is in Lowestoft on the beach in the snow, which was quite funny. It's not going. Oh, sorry. So while we were away, Brett and I also were really lucky to be able to travel to other countries nearby, and one of the highlights I think was leasing a car for a 5-month tenting trip around Europe. So we had a little black Renault Clio, and we were reflecting on this not so long ago that Syria was a real highlight for us. So that's the third from the bottom on the right. Really hospitable people, and it's amazing sights, but it's a bit sad that some of those might no longer be there. So we turned to Dunedin in 2001, and Brett went to work at Roslyn Physiotherapy, where he still is today. And I had a position at our outpatients department at the hospital, and Kathy was my boss then. Hi, Kathy. And I just wanted to say this is also where I met up again with Bridget, who's at the back, who was also a physio at the time. But if you want any new intel on the new Dunedin hospital build, you can talk to Bridget later. But we used to holiday in Nelson with Bridget's family as a child, and so we kind of met up again when we came to Dunedin. So thanks to you and Chris and Andre and Taylor for coming voluntarily, I think, for being amazing friends over the last 20 years. This is a picture of Gareth. So in 2002, I decided that I would pursue some further study. So I started my master's, and Gareth, you were the HOD at the time. I don't know if you remember, but you took a bet on a physio with very limited research background or experience, and I wouldn't be here without you, so thank you very much. So while doing my master's on the hamstrings, I continued working as a physiotherapist at the hospital, and took on another part-time job, and this job, as it turned out, was reasonably instrumental. So I worked as a research physiotherapist delivering the Otago exercise program for visually impaired persons, and here I had the privilege of working with John Campbell and Claire Robertson, who were world-renowned for their work in this area. And this is also when I first met Lee Hale, who was effectively my boss and also an internationally respected researcher. So I just wanted to say thank you to Lee, who's not here tonight, but I think she's online. And Lee's been an amazing mentor. She's always interested in what I'm doing and how is it going. And I've spent a lot of time working with her on the editorial panel of the New Zealand Journal of Physiotherapy. So I finished my master's, started my PhD, and I also worked as an assistant lecturer before starting in the Department of Anatomy in 2007. I've got some good photos. This is the department in 2007, and some of you may recognise, again, perhaps younger versions of yourself. And David Green was the head of department at that time. So around the same time, maybe slightly earlier, I started as a mentee in the academic, John's found himself, in the academic women mentoring program, and I was fortunate to be assigned to Abby Smith. So Abby is here and was based in marine science. This photo was actually taken at Abby's retirement function earlier this year. But I did want to say, Abby, thank you very much. It's been amazing. Abby's given me so much advice and guidance, and I really appreciate it. So it's been a privilege working with you and knowing you over the last 20 years. So thank you very much. So I wanted to take a step back into a bit of research, kind of to where it all started. With the hamstring muscles, so I hope everyone in the department knows where their hamstring muscles are. The back of the thigh, and this consists of a group of 3 muscles. Now, this picture is of Peter Cox, and Latika might remember Peter. He was a medical student who did a summer project many years ago, and also a very able hurdler representing New Zealand. And hurdling is relevant to hamstring injuries, as you'll see in a minute. Before I go on, I also just wanted to let you know that there are some dissection images in places, and these are from body donors who have consented to and graciously and willingly donated their bodies for the purposes of advancing anatomical and medical sciences. So, hamstring injuries are one of the most prominent injuries in sports across both recreational and elite athletes. And the highest rates are reported in sports that involve sudden eccentric or lengthening contractions of the muscle. So this is usually in sports that involve kicking or sprinting, such as soccer, hurdles, rugby, and Australian League rules football, which you can see on the picture on the left. So as you can see from the data, they represent nearly half of all muscle injuries, up to 30% of total injuries. And while the recurrent rates are slowly dropping, they still affect a high proportion of athletes. So people will go on and sustain another hamstring injury. So they're still quite problematic, and in elite sports, they represent a substantial financial burden to clubs and impact not only the performance of the individual, but also of the team. So this is what a hamstring injury may look like, reasonably spectacular. Localised kind of intramuscular bleeding that tracks down the leg. The effects of gravity find it coming down to the calf. And as you can see from the figure on the right, There are a number of factors that contribute to an individual's risk of hamstring injury, including muscle strength, flexibility, and fatigue. So of note and of interest to me is that muscle architecture, or the anatomy of the muscle, has an important role to play. So when we talk about the anatomy of the muscle, this can include parameters such as muscle thickness, fibre length or fibre angle, or the orientation of the fibres in the muscle. And so all of these factors are implicated not only in injury but also in recurrence of injury. But at the time I started my masters, we didn't really know anything much about the detailed anatomy of these muscles. So I started my masters, which was supervised by Susan Mercer. So some of you may remember Susan, who was an anatomist in the department at the time, and she was an excellent mentor, teacher and researcher. She left Otago a few years later, and following some time at the University of Queensland, ended up changing careers and becoming the owner of a very successful vineyard. So I hope it wasn't me that drove her to drink. One of the questions that really interested us was where hamstrings injuries occur, and that question hadn't really been answered. So this it is up there, yes. So this publication was my first, and as it happened, it was in the New Zealand Journal of Physiotherapy. For those of you who do reviews, you'll see that this review only included 9 studies, so not really very big. But the key finding of this review was that the most commonly injured muscle in the hamstrings is the biceps femoris longhid. So that's the muscle of the hamstrings that's on the outside of the thigh. The other question of interest to us was finding out a bit more about the detailed anatomy of the muscles, and this textbook picture provided a bit of inspiration. So what it shows, if you can see, is we've got a grey bit at the top and a grey bit at the bottom, so they're the tendons that attach the muscle to the bone, and then we've got a muscle in the middle. And so that's a very simplified version or example of a muscle. So we kind of really wanted to see if that was right for the hamstrings. So I embarked on a dissection project with an interest in defining the extent and length of the tendons. And so we did look at all the detailed anatomy and reported muscle length and fibre orientation, etc. But kind of key to this presentation is that we showed that the tendons of these muscles are really long. So I do have this here. Oh no, hang on, I'll turn it on, that helps. So on the screen here, this is the biceps femoris longhid. We've got the muscle, and you can see at the bottom these long white tendons, so there's one there, and there's another one at the top that extends through the muscle belly itself. So that was quite important to kind of to know, because hamstring injuries often occur at the part of the tendon that's within the muscle. So from this research, we then, this project led to several others, and I wanted to acknowledge on this slide Richard Story, who was a medical student and took a gap year to do some research. He's now an orthopaedic surgeon. Mark Stringer, who some of you will know, who was a colleague in anatomy, a very talented researcher, clinical anatomist and a paediatric surgeon. And Grant Meikle from Pacific Radiology, who's a valued colleague who helped us with this and has collaborated on a number of different projects as well. So we used a variety of methods to progress this research. In this case, 3D modelling from the hamstrings from body donors, so that's the image on the bottom. And we also looked at the anatomy of the hamstrings in normal, healthy volunteers using MRI. And what you can see from these images, so on the top, again, we've got the hamstring muscles, and then you can see here this dark black line, that's the tendon that goes through the muscle, and the same in the bottom, we've got these long tendons that progress through the length of the muscle. And so from the data there, they extend at least nearly 50% of the length of the muscle, which is important in understanding where injuries occur, because they usually, as I said before, occur along that part of the tendon. And also, just to think back to the picture on the previous slide, is that we don't have 2 tendons at the top and the bottom and a muscle in between, but they expand the length of the muscle. Another way of, I'll just catch myself up here. I've got Julia's notes. Another way to look at muscle architecture is via ultrasound, and this technique is commonly used to assess the hamstring muscles. And in today's world, ultrasound can be used as point-of-care imaging. So the man in the red t-shirt with the cross, the girl looks quite, I don't know what she looks, not really that injured, but he's got, if you can see, he's got a little probe on his finger that he's ultrasounding, perhaps her quadriceps, and you can see he can see the image on his phone. And so, as mentioned before, muscle architecture can be altered with injury, so understanding how the muscle is recovering is important prior to sending someone back to sport. So we were keen to investigate the accuracy of the parameters that we see in ultrasound. So that is, are the ultrasound measurements accurate and reliable? So this work was done by a team of people as well. So on the top left there is Daniel Tosovic from University of Queensland, who was a PhD student. He's now a lecturer over there. Mark Brown, also from the University of Queensland. Next along is Jill Muirhead. Some of you may know Jill. She's an ultrasonographer extraordinaire, sadly retired to Wanaka. And in the bottom row, Harry Aris, who did an honours project, Ryan Timmers from Australian Catholic University, and my colleague Natasha, who we'll talk about a bit later on. It's all good. So on this slide, you can see examples at the bottom of Jill scanning the hamstring muscles in living participants, and then on the right-hand side, Harry and Ryan looking at the muscles in body donors. So we focused on the biceps femoris long head because this is the most commonly injured muscle. So in the body donors, we obtained ultrasound images and then measured the parameters I talked about before, so muscle thickness, fibre length and angle, and then we compared those to what we found on dissection, and that's the bottom image. And in living participants, we've compared some different types of ultrasound techniques. So you can see a couple of different types up there, so static and extended field of view. So without too much detail, we found that ultrasound has excellent repeatability, that the muscle architecture of biceps femoris long head isn't uniform across the muscle, but there's regional variation. And from this, we were also able to provide data on what is kind of the normal ultrasonographic anatomy of the hamstrings, which again is hopefully useful when we're looking at people who have injury. And just in terms of normal ultrasound anatomy, we've also done a number of different projects, and there's a couple of other here I just wanted to touch on. So Marianne Kennedy, who looked at shoulder anatomy in healthy volunteers. She did a large study of 100 people. Helen and I supervised Marianne's PhD. And then the other one is Ines Becker, who looked at the anatomy of the pubic symphysis, so the joint at the front of the pelvis. And she looked at this in healthy volunteers and also a cohort of first-time mums during pregnancy and postpartum. So just a few examples of establishing, what might be normal anatomy. Okay, so I just wanted to switch. Julia's already told you a little bit about this, about the gluteal muscles. And a question for the physios in the room. Can you pick the lady with the gluteal problem? Maybe. So this is a bit controversial. It's supposed to be the one in the middle, but maybe also the one on the right. So what you can see, and I have to do a demonstration, so I'll stand back here. The lady in the middle standing on her left leg and her pelvis. If my gluteals are working well on my left side, my pelvis will stay level, and if they're not, they drop on the other side. So that's the function of the gluteus medius and gluteus minimus, and this was the topic of my PhD and then Tasha's PhD, as well as a number of other clinical and anatomical studies. So just a little bit of background about lateral hip pain. So Julia referred to greater trochanteric pain syndrome, which is the same thing, but it's a bit of a mouthful. So as you can see by the red dot in the picture, this is when people experience pain over the outer aspect of the hip. It usually starts in the absence of any trauma and is common, particularly in women over the age of 50, affecting up to 25% of women. So many will go on and experience chronic symptoms, with up to 30% of women experiencing pain for longer than 5 years. And the pain intensity and physical impairment of lateral hip pain is similar to what we would see in people with end-stage hip osteoarthritis. So it has a reasonably substantial impact on quality of life. There are a number of causes for this, but the focus really is on the gluteal tendons and the problems we would see with those. So, can't get away without a picture of the gluteal muscles. So I'm sure everyone's familiar with your gluteus maximus, which is a large buttock muscle, but there are two others that are deep to that might not be quite so well recognised. So there is gluteus medius, so medius means the middle or the medium-sized muscle, and gluteus minimus, which is deeper to that, which is the smallest of the muscles. So you can see those muscles are attached to the outer aspect of the hip bone and then down onto your femur or your thigh bone. And their main roles are stabilising the hip joint, abducting or moving your leg away from the midline, and as I showed you before, maintaining your pelvis level. So changes in these muscles and tendons are implicated in the cause of lateral hip pain and also other hip-related conditions such as hip osteoarthritis. So here we go. So for part of my PhD, we looked at the hip joints and gluteal muscles in people with lateral hip pain. So my supervisors were Susan, Helen, and Grant was also involved. And at this time, I wanted to say a huge thank you. Helen's looking at me like, thank you to Helen, who was actually the head of department at the time I started this project. And she's been fortunately or unfortunately stuck with me ever since. So I just wanted to say thank you for all you've done. As Julia alluded to, you've had some very large roles in the university and internationally, but you've always had time to pop over and say hello, provide us with advice, tell us what we should and shouldn't be doing. And so we're lucky to have you as a colleague and friend. And you continue doing this as an amazing mentor, even though you're supposed to be retired. But thank you. So for this project, we looked, as I said before, at sorry, I just want to find the right slide. There we go. We used MRI to look at the changes that were occurring around the hip by imaging both the painful and the non-painful side. So on the MRI that you can see there, on the left, you can see a normal looking hip joint. I'll just point up to here. So here are our gluteus medius and gluteus minimus muscles. And what we did find was that people had problems on both the symptomatic and the asymptomatic hips, also known as a false positive. So this was a little bit of a I don't know, landmine kind of thrown at us at the time because we didn't really expect it, but we do know that now that often what you see on imaging doesn't necessarily relate to person's symptoms and vice versa. So on the image on the right here, you can see this is the normal gluteus muscle, and then on this one you can see there's a whole lot of white. That's where the muscle has been replaced with fat. So that would be an example of a pathological muscle, and in this context it occurred with a tear to the gluteal tendon. So that was kind of part of the PhD that we looked at. And the other part is that we looked at the accuracy of clinical tests for diagnosing lateral hip pain. So the examples on the right are some of the tests that we use. So Mum, you always said you've got good legs, so here they are. And it is from a while ago, and it's also handy to have Brett, who was the assisting physio in the photograph. So from this work, we're able to provide some guidelines around the utility or the accuracy of the clinical tests for diagnosing lateral hip pain. I've listed three there, so palpation, resisted hip abduction, which is the picture on the bottom, and then standing on one leg. And since this study has been done, there have been a number of studies since this time that have shown that a battery of clinical tests, so a combination of different tests, which actually do include these three, are most effective in diagnosing lateral hip pain. So I just wanted to deviate a little because we're also interested in finding out more about the anatomy of the gluteal muscles, in particular gluteus medius and minimus. So much like the hamstrings, we started exploring the anatomy of these muscles first using dissection, and then we moved to MRI and ultrasound. So this project was driven by Tash, who was my very first PhD student. And Tash and I, she's now a much valued colleague who we work pretty closely together, and pretty incredible person as well. So thanks, Tash, for however many years it's been. In terms of dissection, many of the previous studies didn't take nerve patterns into account. And so if you look at the picture at the top, that's gluteus medius, and you'll see there's lots of different coloured pins. So this is where Tash is very meticulously dissecting out all of the nerve branches, and the different colours represent the different nerve branches. And so from the information relating to the patterns of innervation, as well as the attachment site and fibre orientation of the muscle, we were able to show that the muscle is actually made of different compartments. And so the two images across from that, which are coloured, so gluteus medius consists of 3 compartments, so an anterior or front, a middle, and then a posterior or the back section of the muscle. And gluteus minimus consists of 2 compartments, an anterior and posterior. And that's really important from a functional perspective because these compartments can work independently, so might be able to do slightly different actions. And also from a pathology perspective when we look at where the changes happen in the muscles. So, as an example, so Tasha's work was picked up by colleagues at La Trobe University. So this is Rod Green, Anita Zacharias, and Adam Simchu. So this might look a little macabre, but what they've done here is they've inserted fine wire needles, so they're quite long, but reasonably thin, into the different compartments of the muscle. And then they ask people to do different tasks. So the picture on the left is someone's going to do walking, and they've got cameras set up as well. And on the right, you can see all the little black bits there, they're electrodes stuck into the different parts of the muscle. And this person is raising their leg up to the side, which is one of the actions of these muscles. So this is called electromyography, so looking at the firing pattern of the muscles. And what they found out from this is that, as we now know pretty well, is that the different compartments of each muscle are more active in some exercises compared to others. And this is important when we think about treating hip-related pain and dysfunction, which I'll come back to in a minute. Another aspect of understanding gluteal anatomy links to be able to look at changes in muscle size and activity. And so in recent years, we've been able to measure gluteal muscle size using semi-automated machine learning. And for this, you manually trace around the outlines of the muscle. So you can see on A and B some different colours. So there are the gluteal muscles. And that then in turn builds up a 3D image of the muscles. And you can also quantify the size. So for this work, I'd like to acknowledge Peter Lawrenson, who was a postdoc with us a few years ago, and he now works for Queensland Health. And while he was here, Pete contributed his expertise to several MRI and hip-related projects. And also Brooklyn McDonald-Tibble, who did her postgraduate diploma in science with Tash and I this year and looked at gluteal muscle size and quality. What you can see on the right, where the blue arrows are some parts of the muscles that have been infiltrated with fat that I looked at before. So what we know that in people with hip pain, it's usually the gluteus minimus that's affected, and in lateral hip pain, often the posterior compartment. So, no one's seen this yet. So understanding the functions of the different compartments of the gluteals alongside changes in muscle size and fatty infiltration can help us inform the development of exercise programs for people with hip pain. So again, lucky to work with a La Trobe team on this project, and this time we looked at hip osteoarthritis. And so in this study, we were looking at whether if we gave people a targeted exercise program targeting the functions of the gluteals, whether we could change gluteal muscle size and strength. So it's a randomized controlled trial. People were assigned either to a targeted strengthening group or a sham exercise program. This is Brett doing some of the exercises, and trying to target gluteus minimus, we added in a rotatory component to our normal hip abduction exercises, and also some pelvic stability exercises. So what we showed from this project was that these exercises, the intervention was only 12 weeks, so and also, as I should have said, that this happened during COVID, so we weren't able to recruit our whole cohort of participants, so the trial was likely underpowered. But we did show that the targeted exercise increased gluteus minimus size or volume in the targeted intervention group in both the symptomatic and the asymptomatic side. And also, although it wasn't significant, we saw a reduction in the fatty infiltration in gluteus minimus and medius as well. So that's really promising, saying that if we can target these muscles, then we might be able to make a difference to them in these people. And finally, just on this, in terms of lateral hip pain, I've also been privileged to work alongside these ladies who are experts in the field. So this was taken at the conference in Basel last year. Alison Grimaldi and Angie Ferron from Australia and Helen French from Ireland. And so the couple of studies we've done is to report what physiotherapists consider important in the diagnosis and treatment of lateral hip pain. Last bit of research. So staying with the pelvic region, over the last decade we've also looked into different aspects of pelvic girdle pain, and particularly what may happen during pregnancy and postpartum. So another arm of this research related to pelvic floor muscle training. And so I was going to say that everyone probably understands urinary incontinence, but that would probably come out wrong. So the context of this research is that it is important to urinary incontinence, which refers to the involuntary leakage of urine and is a stigmatising condition that has a big impact on quality of life. And most studies show that urinary incontinence is experienced by between 25 and 45% of women at some stage in their life. And for many women, the onset is during pregnancy. It's worst kind of in the second and third trimesters, and about 1/3 of people will continue to have urinary incontinence 3 months after giving birth. And for some, this becomes a long-term problem. So I've been fortunate to work with Jean Hayes-Smith for a number of years. And Jean, I think, is online, so I'll say hello to Jean. And I can kind of clearly remember the day when we started a conversation about this, and that was when I was standing on the one-way north, close to where my car was parked. And Jean offered me the opportunity to join her Cochrane review team, and I'm very grateful for this. I've learnt so much about systematic reviews and meta-analyses, and Jean has been very generous with her support and advice, and also a lot of fun to work with. So thank you, Jean. You will see here that we've completed 3 updates of 2 reviews, which represent the synthesis of a large amount of data and a lot of teamwork from people across different countries. There's not enough time to go into the details, but the main messages here are that you should do pelvic floor muscle exercise training, and if pregnant women who are continent start pelvic floor muscle training during pregnancy, it's most likely to be effective in preventing them from becoming incontinent later in pregnancy or postpartum. So that's kind of the key message from the top review there. And it was pretty cool because this was picked up by the World Health Organization and included in some of their guidelines as well. So just to finish, a little bit about teaching and community-related activities, both with students and healthcare professionals. So our students, as some know in the room, are often the main reasons that we work here. Their curiosity and willingness to learn keeps us going. I also just wanted to say we really appreciate our great teaching spaces and resources that are supported and looked after by amazing technical and teaching teams. So thank you to everyone who is in the room. I know you're spread around the place. I would have loved to have edited everyone's photos, but I was scared I would miss someone off. So part of the teaching experience is also our colleagues who we can share a laugh or two with and work quite closely with. So the bottom photo on the left, this was during COVID. That's myself and Tash, Phil, who's also a valued colleague who's somewhere in Europe on RSL at the moment, and Latika. I told Latika there was a photo of her. We needed this was an emergency Zoom call during COVID, and the emergency was that Latika needed help to figure out how to make a breakout room on Zoom. So I think it took us some time and quite a lot of laughter, but we did get there, and I'm pretty sure now Latika, you're an ace at that. We've also been able to put to good use our combined anatomy and clinical interests, and this is around what students might need to know in terms of anatomy. And so working again with a great team, Alex Webb from Australian National University, Rod Green from La Trobe, Laura Whitburn from La Trobe, Tash, and also Brooke Willoughby, who was anatomy student turned medical student, and I think she should be finishing off this year. So what we did is we started with a project around musculoskeletal anatomy for medical students, then did the same for physiotherapy students before another study looking at neuroanatomy. So we're hopeful that the resulting 3 publications will be a useful guide for anatomists and health professionals as to what students should know in terms of their anatomy before they go into the public arena. Julia touched on this before, but this is probably one of the highlights of my career. So for the last 8 years, I've had the privilege of being involved with Grey's Anatomy, so that's the book, not the TV program. And the new edition, so the 43rd edition, is going to be released next week. So as Julia said, I've been the section editor of the pelvis and lower limb section. This has been an amazing experience, an opportunity to write, edit, learn new skills, meet new people. This is a picture with Susan Standring, who's based in the UK, and she's been involved in Grey's Anatomy for approximately 45 years, which is remarkable. She's the editor-in-chief, has been for quite some time. She was awarded an MBE for services to anatomical education in 2015, and we were fortunate to be able to have her come to Dunedin 2 years ago when we were hosting a conference, and that was really great. I think having her daughter, one of her daughters in Wellington, was also useful. Just a couple more slides. I've been fortunate to contribute to many community outreach events. The top is an example of a workshop that Jiren, Amanda and I ran for a physiotherapist, and I had to say hello to Jiren, who's currently in Singapore and is way back from India, so he's also a great colleague. So while they're here, they come and physios revisit their anatomy, but we really like doing these workshops because we always learn something new from them as well. The bottom is a New Zealand Journal Physiotherapy team. It's a year or two old now. We've got some new people who've joined our team. We've got a lot of collective years between us, but I'm proud of what we've achieved together, and so I wanted to say thank you to the team. And finally, these are just some pictures that we have school students come for outreach events such as Hands-On at Otago or the Science Academy. They learn lots, we have lots of fun as well. They usually come at the beginning of the year. And one of the great things about this as well is that we often get to follow students through their journey. So I use John as an example. He's not here, he doesn't know this. But John is in the top photo, he's the third from the right. And he came in 2019, I think, to do Hands-On at Otago. He then went on to a science degree, is now doing medicine, and this year he also joined our teaching team. So we're kind of really nice to see people progress through their careers. So it does take a village. We have quite a large family, so I'd like to say a big thank you to everyone here for their support. I'd also particularly like to say hello to Robin, who on Tuesday had her hip joint replaced, which is quite ironic given the topic of the talk. But we hope, Robin, that you're recovering really well. To Brett, I couldn't do it without you. Clearly the pictures show that all. And to Kate and Nick, you're both awesome, and we're really proud, Kate's not looking, at who you are and who you've become. So we look forward to many more summers of cricket. So for those of you who know cricket, you'll know that this is not in Dunedin. This is Alexandra, but we have met many friends on the side of the cricket or the soccer field through our involvement with the kids' schools. So thanks to everyone, including my gym and running buddies. And I'd just like to say a big thank you to all my colleagues, those in anatomy, past and present. We have a really diverse department, and I'm lucky to work with you all. I'd especially like to thank our teaching, administrative and technical teams for all that you do behind the scenes. You guys are awesome. A huge thanks to CARG, you know who you are. Also, many colleagues, not only in anatomy and physiotherapy, but around the faculty and the university, our body donors and study participants, library team, thanks Thelma, you've done so much for us over the years, our research funders, students, friends at the Australian and New Zealand Association of Clinical Anatomists, Physiotherapy New Zealand, University of Otago, and anyone else who I haven't thanked. Anyway, the final slide actually belongs to Gareth. I don't know if you remember this, Gareth, but this is a postcard you gave me in 2007 when I started my lectureship job. These are both sides of it. And it says, I can't read because I don't have my glasses on, congratulations on being offered the anatomy lectureship. I thought this card was appropriate in the light of your decision making, which work will get you, anatomy or physiotherapy. The fish are just beneath the surface, and so I hope I've been able to do justice to them both. So kia ora, thanks everyone for listening. Done.
Tēnā koutou katoa, ko Helen Nicholson toku ingoa. Thank you for letting me speak, Steph. My name's Helen Nicholson and I'm an emerita professor. Steph, I know that you don't like having a fuss made about you in public, but, and you may be a little nervous about what I'm going to say, but Steph, you're a special person, and I'd like to add a few words to compliment the excellent talk you've just given us. So I first met Steph Mackenzie in 2002 when she was studying for an MSc, and then had the pleasure of co-supervising her PhD, as you've heard. Since then, I've enjoyed getting to know Steph as a friend, and particularly watching her develop into an excellent academic and colleague. Going back to her PhD, Steph didn't really need much supervising. She was clear what she wanted to do. She learnt quickly and got on and completed her thesis, as well as juggling various part-time jobs at the same time. And I think that's something that typifies Steph. She gets things done. She sees what's needed, and you know that if you ask her to do something, it will be done in a timely manner. As you've heard, Steph's a great teacher who's able to combine her clinical understanding of physiotherapy with anatomy so that students really understand the relevance of what they're learning. I've also had the opportunity to co-supervise with her, and I know that she really cares for her students and her colleagues and always goes the extra mile to support them. And she's played an important role in developing the next generation of clinical anatomists, teachers and researchers, both here and overseas, because she's been involved in, most recently, in a pilot project to help emerging anatomists in Africa. She's been involved in quite a fun session that we had in Kuala Lumpur recently, where we had lots of emergent and middle career anatomists who wanted to be mentored. And that, I think, typifies a good leader, that they actually want to develop the next generation. She's known internationally, and you've heard a bit about Gray's Anatomy. Not many people are invited to be a section editor of Gray's Anatomy, and not many are invited back to do the next edition. And I don't think people understand how much work is involved in that role. It's a huge role, and Steph just does it with everything else that she does. So I think that's really great. In terms of her leadership, Steph has played a pivotal role in the Australian and New Zealand Association of Clinical Anatomy, and most recently has stepped into the president's role and provided the strong leadership that was needed at this time. She's organised significant international conferences, and she's organised Tash and I to do our bit to help organise those conferences. And she's more recently taken on a key role as secretary for the International Federation of Association of Anatomists. Steph, you're a great travelling companion. We've been to various conferences over the world, and I guess what goes on tour stays on tour. But most recently, or more last year, I think, thank you for driving us up to Christchurch in the middle of the night when our flight was cancelled, and thanks for Steph's mum and dad for taking the car back today. So thank you for that. And I know that whānau is very important to you, and I'd like to echo your thanks to Brett, because I know that when the time gets tough, you need your partner there to support you. And Kate and Nick, thank you very much for sharing your mum and supporting her in her journey. Steph, it's been a great pleasure working with you over the years. You fully deserve to be a professor, and I'm sure that you will continue to develop your career. The Department of Anatomy is very fortunate to have you as part of their whānau. Ngā mihi nui. Thank you. I thought it would match your gown, you see. And now I'm going to hand over to Greg.
Kia ora koutou, ko Greg Anderson tōku ingoa, ko aho hoki te upoku o te tare kiku at University of Otago. So I'm the current head of the department, so Steph's boss, and it's my job just to echo some of the superlatives that Helen has just said there. Steph, I want to begin just by giving an enormous thank you for the load that you carry with me in running this department. So for a long time in the Department of Anatomy, we've had a head of department and a deputy head of department, which is usually brackets teaching. And the head of the department maybe gets all the glory, but the deputy HOD teaching really shoulders the backbone of the work. And just to give some context to that, the Department of Anatomy teaches, I tried to count them, probably close on 50 papers we teach into numerous programs, not just our BSc in anatomy, but BSc BSc in neuroscience, BSc in genetics, physiotherapy, of course, Bachelor of Biomedical Science, forensic science, and the list goes on. We do an enormous amount of teaching. I think it's probably safe to say we are the biggest output of teaching, biggest department, does the most teaching at the University of Otago. So it's incredibly complex, and I don't have to worry about that because Steph does, and it's really, it is, you know, I can forget the names of the papers that we teach because Steph doesn't. So I just want to really thank you, Steph, for the enormous, it really is the backbone of the Department of Anatomy. And it's really been the health of the Department of Anatomy as well. For a long time, all the teaching that we did was brought in a lot of income to the Department of Anatomy, and it supported everything we did. Our research and our infrastructure. These days they do the accounting a bit differently, and we do it just for love. But still, Steph does it, and so thank you very much. So the other area that I think you show me up, Steph, is your amazing research, in particular in the way that you use the incredible resource we have in the Department of Anatomy, and in particular I'm speaking about the bequested bodies. So every year, close on 80 or 100 people donate their bodies to the University of Otago for teaching, physiotherapy students, medical students, other students, but also for research. And in your research, Steph, you've made extensive use of that. And I think we've heard tonight how your research blends basic biology, learning about innovation, variation, but it's also highly translational as well. And those two things going on together in the same study is quite special, I think. And so I've just been delighted to hear about the wonderful research that you do and the difference that it makes as well. So I'm not going to talk anymore. Thank you very much. I loved hearing your talk, and I think in the end you really loved doing it. I could tell listening to you. So thank you so much. Megan. I have one job to do. We have this gift for you, and so thank you very much.